So today we'll be talking about anticoagulants. We have different types of cardiac medication. So anticoagulants is one of them. And these anticoagulants, there are a lot of things. I didn't want to record this particular lecture because there are a lot of things embedded in it that I want you to know, that you need to know as nurses. So that is why I've decided not to record it. I wanted to make it a live section. Unfortunately, half of the class is not even here. So anticoagulants is a very important medication. Very, very important for you to know as nurses. It's not something that you can just take with levity. We make use of it. We've been hearing Heparin, Warfarin, you know. But there are key things, major things you need to know about this particular anticoagulant. You know, we have been using it, you give it to your patient, when your patient is going for surgery, you make sure you discontinue it. Why are you discontinuing it? Why? What are the key things you need to know about it? So let's go to anticoagulants. Anticoagulant prevents the extension and formation of clots by inhibiting factors in the clotting cascade and decreasing blood coagulability. So what anticoagulant does, in short, is that it prevents formation of clots, or if a thrombus has already formed, anticoagulants will prevent that thrombus from getting bigger. So that is the work of anticoagulants. It either prevents a thrombus or clot from being formed, or if the clot has already formed, if the clot has already formed, it will prevent it from getting bigger. I don't know if I'm making sense. So that is how anticoagulants work. It prevents it from getting bigger. But if clot has already formed, anticoagulants cannot break it. So its own work is to what? Is to prevent the blood from clotting. So anticoagulants are administered when there is evidence of or likelihood of clot formation. Now let's take a look at this particular slide. We have different types of anticoagulants. We have the oral anticoagulants and we have the parenteral. So these are the types. I've grouped it into two, oral and parenteral. Under the oral, we have the apixaban, the dabigatran, ethylates, mesylate. We have ecdozaban, rivaroxaban, warfarin sodium. Under the parenteral, agatroban, bivalirudin, dalteparin, desirudin, enoxaparin, fondaparin, heparin sodium. So it has been grouped into what? Into two, oral and parenteral. So now we have different types of what? Let's talk about the key medications under anticoagulants that we have been using in the world. That we have been administering to our patients. What are the things we need to know about it? Now let's start with heparin. Heparin is an indirect thrombin inhibitors. Indirect thrombin inhibitors. And if we say, indirect thrombin inhibitors, what do we mean? This is just an English word, indirect. That means heparin inhibits thrombin. You know that thrombin plays an important role in what? In blood coagulation. You know that in the blood coagulation pathway, I think we were taught in School of Nursing, blood coagulation pathway, I think we have the, who can tell me, please just respond, because I don't like talking alone in my class. Can you just respond in the comment section? How many pathways do we have? Who can just mention the pathways that we have in blood coagulation pathway? Please just type. Because I want to bring out something. How many pathways? Thank you. We have 3 pathways. Please mention them. Yes, 3. Okay, 3. What are the pathways? Please, can you mention? Those pathways have name now. What are the names? You're just saying 3 pathways. Okay, I know. They should have name. We have the intrinsic and the extrinsic pathway, and we have the common pathway. That is what I was expecting you to say in blood coagulation pathway, because we can't talk about yes, intrinsic. Thank you. This is what I was expecting, actually. Thank you very much. So there is no way you can talk about all these things without referring to blood coagulation pathway. You know that, okay, prothrombin has to be converted to thrombin. And thrombin will help in conversion of fibrinogen to fibrin. You know, all these. And as a result of some what? Also, or as a result of some factors. So, but here, we are not here to discuss blood coagulation pathway, actually. That is not why we are here. If you want to know it, you can read about it, or you want to remind yourself you have forgotten about it, you can read about it. That is not why we are here. So I just want to bring something out. When I said, okay, heparin is an indirect thrombin inhibitors. So our heparin, how does it work? What is the mode of action? So it cannot inhibit thrombin by itself. Heparin is an indirect thrombin inhibitor because it cannot inhibit thrombin. There's something we call antithrombin 3 in the blood. So this antithrombin, it is a natural is a natural substance in the body that helps to inhibit thrombin. And once thrombin is inhibited, blood coagulation can never occur because it is thrombin that will help fibrinogen to convert to fibrin. So what heparin does is that it helps to what? It connects with what? Antithrombin 3. It inhibits, it exerts a direct effect on blood coagulation by enhancing the inhibitory action of antithrombin 3. So that antithrombin 3 is a natural what? It's a natural substance in the body that helps to what? To inhibit thrombin. So heparin cannot come and inhibit thrombin by itself. That is what we call it indirect thrombin inhibitors. So it needs the help of what? Antithrombin 3 to be able to inhibit thrombin. Please, I hope I'm not speaking in Spanish. Please, does my explanation, does it make any sense to you? So that is the meaning of indirect thrombin inhibitors. So it cannot do it by itself. It is dependent on something. It is depending. It has to depend on something to help it out. So, okay, thank you. Okay, so it is depending on what? Antithrombin 3. So that's why I say, okay, it exerts a direct effect on blood coagulation by enhancing the inhibitory action of antithrombin on several factors. Essential, we have several factors, so I'm not going to mention those factors now. Essential to normal blood clotting, thereby blocking the conversion of prothrombin to thrombin and fibrinogen to what? Fibrin. So heparin works in the intrinsic pathway. So when you read about the blood coagulation pathway, you will see that heparin works in the intrinsic pathway. Now, what are the indications? What are the indications? Okay, which conditions can you use? Which conditions can you use heparin? Heparin is what? It is rapid acting. It starts acting within few minutes. When you administer, when you need a fast anticoagulant, just think of what? Think of heparin. You won't go and give warfarin. When you need a fast anticoagulant, please take notes. You give what? You give heparin because it is rapid acting. So it is used to prevent and treat what? Deep vein thrombosis. You can use it to prevent it. You know, I told you that anticoagulants prevent what? It prevents thrombus. Or if thrombus had already been formed, it will what? It will prevent them from what? From getting bigger, from growing. You can also use it in pulmonary embolism and emboli in atrial fibrillation. So you can also use it in atrial fibrillation. Atrial fibrillation is just one of the abnormal cardiac rhythm. I think I mentioned it in my video. So it's one of the abnormal cardiac rhythm in which the atrium just keep quivering. It just keep, normally blood flow through the heart, the two atrium should contract at the same time. When they contract, the valves will open and they will go into the ventricle. But in atrial fibrillation, this doesn't happen. The atrium cannot contract properly, just keep quivering, and before you know it, the blood stays there, and it will get to a time it will start coagulating. A part of it can detach, can dislodge. So that is just the major thing that happens in atrial fibrillation. So you can also use this anticoagulant, this particular heparin. You can use it in a patient with atrial fibrillation. It can also be used to treat using DIC. So we know the meaning of DIC, disseminated intravascular coagulation. We all know that disease condition. Then it is preferred anticoagulant during pregnancy. Yes, heparin is safe, especially low molecular weight heparin, not just heparin. Heparin also has another type. We call it low molecular weight heparin. It can be administered to pregnant women. So it is preferred anticoagulant during pregnancy. It doesn't cross the placenta or enter the breast milk. Then prevents coagulation in heart-lung machines, dialyzers, patients on dialysis, you can actually inject this heparin to actually prevents coagulation. Then it is used as an adjunct to thrombolytic therapy of acute myocardial infarction. When you place a patient on thrombolytics, we are still going to talk about thrombolytics. You can also use it as an adjunct treatment. Now, what are the contraindications? Definitely, you want to give it to patients with bleeding disorders, bleeding tendencies, patient that has hemophilia or any kind of bleeding disorders. You wouldn't want to give it to them. A patient with dissecting aneurysm, it is contraindicated in a patient with hemorrhagic stroke. You don't want to give it to a patient with hemorrhagic stroke. It is It is contraindicated. Patient with peptic ulcer, thrombocytopenia. Thrombocytopenia. I hope you all know the meaning of this thing that I'm saying. Thrombocytopenia. Please, you can tell me the meaning of thrombocytopenia. What is thrombocytopenia? No, we have different terms. We have neutropenia. We have thrombocytopenia. Please, you can tell me. What do we mean by thrombocytopenia? And why do you think we cannot use it in a patient with thrombocytopenia? Please, let's comment. What is thrombocytopenia and why is it contraindicated? Why is it contraindicated? Platelet deficiency, thank you. So why do you think heparin is contraindicated in a patient with thrombocytopenia? Yeah, low platelets, yes. Why is heparin contraindicated? Why can't you give it to a patient with low platelets? Bleeding, no, don't bleeding. I don't want to hear the word bleeding. Tell me why. It will cause bleeding. I know, it will cause bleeding. Why? There is something I want you to say that you are not saying. Yes, insufficient platelets. Why? What is going on? Present, there is delayed clotting time present already to affect clotting factors. You know that platelet is responsible for what? Plays a major role in blood clotting. And this patient, due to low platelet, okay, thank you very much. Platelets are needed as factor for clotting of blood. So platelet that plays a major role in blood clotting has already what? It has been reduced. Please, what is the normal platelet count? Please, let's respond. Don't Google it. What is the normal platelet count? Please write what you know. What is the normal platelet count? Thank you very much. 150 to 450. It can be 150 to 400. Fine. Thank you. Thank you. So platelet has already been reduced. So you now still go and give this patient heparin. No, it is not done. So that is just the reason why. Then uncontrollable bleeding that you can't control. You don't want to make the blood to become thinner by giving heparin. Threatened abortion, postoperative patients, especially high brain, spinal cord surgeries, lumbar punctures. All these are contraindicated, please. And regional anesthesia. What are the side effects that you can get? There might be what? Reaction. There might be reaction at the site of the injection. Then there's heparin-induced thrombocytopenia. Please, who can tell me, have you heard this word before? Heparin-induced thrombocytopenia. Please, who can tell me the meaning of heparin? We call it HIT. HIT. That's the short form of the word. HIT. Who can tell me the meaning? What do you understand when we say, okay, someone has heparin-induced thrombocytopenia? Definitely, heparin induced it. Something has happened. You have administered heparin. You know it's a side effect. Low platelet count resulting from heparin administration. Yes, fine. But there is something that I want you to say about it. You are right. So low platelet counts resulting from heparin administration. Yes. Due to excessive injection of heparin, reduction in platelet counts as a result of heparin. Yes. There's something I'm looking for actually. Excessive administration of heparin. Okay, so because of our time, because we still have a lot to do, let me just explain. Heparin-induced thrombocytopenia means, okay, take for instance now, the doctor says, oh yeah, order this particular, the way they write their order, and they say, okay, commence this patient, okay, it's a condition whereby the use of heparin causes reduction, okay, so I commence this patient on heparin, and maybe you commence the heparin, what is the time now? I think the time should be around It should be around 5. Okay, this is 502. You commence your patient on heparin around 502 today. I hope you are listening to me. You commence that patient on heparin at 502. And by 502 tomorrow, you check, you decided to monitor, when patients are on anticoagulants, you don't just leave them. You will notice that they'll keep ordering all these blood lab. You'll be monitoring their level of platelets. And by 5:02 p.m. tomorrow, you now decided to check the platelet count of your patients. And you now saw that it has reduced. The platelet count has reduced by what? By half. The normal platelet count is 150 to what? To 400,000. You now check your patient platelet count by 5:02 p.m. tomorrow. You are now seeing 200 or you are seeing 100. Then you know that, there is trouble. That is what is known as what? Heparin-induced thrombocytopenia. So that means the level of platelets will decrease by half. That is what happened. That is the meaning of heparin-induced. So the number of platelets of your patients, it will decrease by what? Half within 24 hours. So once you see that, then what will you do? You stop immediately. That means your patient is having what is known as what? Heparin-induced thrombocytopenia. I hope I'm making sense. Who doesn't understand what I just said? Is there anybody that doesn't understand what I just said? Well understood. That is the meaning. So within 24 hours, the platelet count will reduce drastically by half. By 50. Okay, let me use the word 50% then. It will reduce by 50%. The normal platelet count is 150 to 400. But within 24 hours, it will reduce by what? By half. So by the time you monitor the platelet count, you see that, okay, notice that it has reduced drastically because you have commenced your patient on what? Heparin. Then another thing is osteoporosis. These are miscellaneous side effects anyway. But the most important side effect of heparin is this heparin-induced thrombocytopenia. Now, nursing responsibilities. Let's go to nursing responsibilities. This is where you have a major work to do as a nurse when your patient is on anticoagulants. You monitor the what? The PTT and the APTT. Please type in the comment section, what is PTT and APTT? And what is the normal APTT? I mean, normal PTT. Who can tell me the normal range? Yes. PTT is different from PT. Please don't mix it up. PT is different from PTT. They are not the same thing. Thank you. Partial thromboplastin time. Partial thromboplastin time is not prothrombin time. Partial thromboplastin time, it is not the same thing as prothrombin time. They are two different things. They have nothing in common. So please, what is the normal range of PTT? What is the normal range? They are all in our lab investigation forms in the world. We all have them. Those range are there. So please tell me what is the normal PT time? PTT, sorry. 25 to 37. Not really. Partial thromboplastin time. 25 to 35. We are getting there. 20 to 40. 25 to 35. Okay. All right, let's continue. So what is that partial? What do you understand when they say partial thromboplastin time? What do you mean? When we say it a lot. Oh, want to check, they are checking the PTT of the patient. What do you understand when we say, okay, this patient's partial thromboplastin time? What does it mean? PTT is not 11 to 12.5. That is PT. That is PT from thrombin time. Please don't mix it up. Partial thromboplastin time is different from prothrombin time. Nurses, they are not the same thing. So when they say, okay, partial thromboplastin time, what is the meaning? What do you understand? This is professional class. You are all bosses at your different places of work. What do you mean? How long? Thank you. How long it takes for blood to clot? Thank you very much. Yes, how long? The number of minutes. That is partial thromboplastin time. How long, how many minutes will it take for, how many seconds will it take for this patient's blood to clot? That is why, they do it by the bedside. Doctors come in, they want to check it. You don't just want to place your patients on anticoagulants. You need to monitor this particular PTT. Very, very important. Doctors, they don't joke with it. They don't joke, but unfortunately, we nurses, most of us, I'm not saying everybody, we don't actually notice, we don't usually care about all these things, just leave everything for the doctor. It is not the doctor's duty. So it is the number of minutes that it takes for your what? For the patient's blood to clot, so that you know that, okay, is this patient, can we increase the dose of heparin, or should we reduce it, or should we even stop it? So this is what will help you. And the normal is 30 to 40 seconds. That is the normal. When a patient is not on what? Heparin. That is when your patient is not on heparin. No, please take notes. When that is normal, okay, like, okay, what is the normal time that we are expecting the blood to clot when the patient is not on what? Anticoagulant. I think it is around 30 to what? 40 seconds. There might be different range according to different organization hospital policy, but the one I know is 30 to 40 seconds. So if you now put your patient on anticoagulants, okay, let's stick to what? 30 to 40 seconds now for our heparin. So let's just pick that as our own range for this class. 30 to what? 40 seconds. Now, if you now commence your patient on heparin, what will happen to that 30 to 40 seconds? How long will it now take for the blood to clot? I'm asking an applied question now. The normal is 30 to 40 seconds. I'm the doctor. I now come into the ward. I place the patient on anticoagulants. What do you expect? What will happen to that time? Since the patient is now on anticoagulants, the normal time for your patient is 30 to 40 seconds without anticoagulant. I now commence that patient on anticoagulant, heparin. What will happen to the partial thromboplastin time? Thank you. It will be prolonged. Thank you. That means it will increase. It will no longer clot within what? Within 30 to 40 seconds. We want to extend the time that the blood will clot. You are extending that time. So that is what we are doing. That is just the simple thing behind anticoagulant. We want to extend the time that it will take for the patient's blood to clot. That is what you are doing. Now, if you now put your patient on anticoagulants, you will now multiply that range by 1.5. So the therapeutic range will now be 1.5 to 2.5 to get the therapeutic range. If you have a pen, you can write it down. So the normal is 30 to 40 seconds. But by the time you now put your patient, yes, 1.5 to 2.5, the therapeutic range. So that means it will increase by 1. So that means if you times 30 times 1.5, it will give you what? 45. If you times 40 by 2.5, it will give you 100. It will give you 100. So that when you now check, that means your patient blood, it can now take about 45 to what? 100 seconds once they are on anticoagulants. Please, am I making sense, please? I hope we are getting what I am saying. Thank you very much. Thank you very much. So, so it will now increase. So you should know. So when a patient is now on anticoagulant and you monitor the PTT, and maybe it gives you 50 seconds. That is okay. That is okay. You will not be panicking that this is too long now, because the patient is already on anticoagulant. So we want to extend the clotting time. But now, take for instance, if you put your patient on anticoagulant, let me ask this question. If you put your patient on anticoagulants and you are getting the thromboplastin time, the partial thromboplastin time, you now got like 20 seconds. What will you do as a nurse? Or what do you expect the doctor to do in such a situation? The patient has already been on anticoagulants for like, let's say 2 or 3 days, and you are now getting 20 seconds. What does it mean? Someone say, I will stop it. Why will I stop it? Please listen to my question again. Your patient has been on anticoagulants. You check the thromboplastin time, and you are not getting 20 seconds. And it's giving you 20 seconds. What will happen? Thank you. You will increase the dose. You will increase the dose. That means your heparin is not working. It doesn't make any sense. Why will you put your patient on anticoagulants and the thromboplastin, the partial thromboplastin time will now be giving you 20 seconds? It should give you nothing less than 45 seconds because I just told you that it will increase by 1.5 to 2.5. So you should be having between 45 to 100. But in case you now checked and you are now getting one and the blood of the patient is taking 120 seconds to clot, what will you do? Or it's taking 150 seconds, what will you do? What does it mean? If it's taking like 100, I mean, it's taking like 120, thank you. You reduce the dose. You reduce the dose. Thank you very much. I think you have gotten what I wanted you to get. Oh, please, very, very important. Very, very important. I have to take my time to explain. So let's go back to our explanation. So you monitor the partial thromboplastin time. You monitor the platelet. Very important. Please do not ignore the platelets. Very, very important. You still have to monitor the platelets because I told you that it can cause what? Heparin-induced thrombocytopenia. Caution the patient not to take aspirin or any medication that decreases platelet because aspirin is an antiplatelet medication. So it will begin to break down the platelets. You should reduce the number of platelets. So you don't want to administer heparin with what? With aspirin. You don't want to give it with drugs like clopidogrel. They are all antiplatelets. Administer it either IV or subcutaneously. That is how to administer what? Heparin. You don't give it high hem. You can only give it IV and subcut. Apply firm pressure for about 1 to 2 minutes. And do not massage. You don't rub the site after giving heparin. You don't rub the site. You don't rub. And you can tell me the size of the syringe that we use for heparin. Thank God you have been administering it. So this is what you do every day. Yeah, I've explained the activated. It's the same thing. That's what I said. Activated means, okay, you have put your patient on anticoagulants and it's increased by 1.5 to 2.5. I've explained everything together. So please, what is the size of the syringe? Very important. What's the size or the inches of the syringe that we use? You can tell me. 1 cc. 1 cc as how? I'm talking about the inches. The gauge, we know we have all those needles and then, is it 20? Okay, okay, somebody has responded. 25 to 26 G, thank you. 22 cc, no. What about the length of the needle? These are the things you should take note as nurses. Very important, please. Yeah, 25 to 20. So, okay, someone said 25 to 26 G. Yeah, it can be 25 to 20 G. Then 16 mm. Your needle should be around 16 mm. Then 5/8 inches. Length of the needle, sorry. Yeah, length 16. 5/8 inches. Very, very important. Very important. Very important. Now, let's talk about bleeding precautions. You maintain bleeding precautions. Please comment. What are the bleeding precautions that you should maintain? What do you understand by bleeding precautions? Nurses, when your patient is on anticoagulant, it is your duty to maintain bleeding precautions. So let's comment. What are the bleeding precautions you have been maintaining? We have all been administering anticoagulants to our patients in the ward. We have been giving them heparin. Abi? So what are the bleeding precautions that we maintain? Let's mention them. So that will show that whether we have been doing it or not. It is your response that will determine whether you have been doing it or not. What are the bleeding precautions? When our patient that you have been doing, not to cut their nails. Okay. Any other one? No IM injections. Thank you. Okay. Preventing cuts or injuries. Thank you very much. Reduce needle stick. Thank you. Preventing aspirin administration. Okay. Patient should not use hard brush. Thank you. Should avoid taking NSAIDs. Use of soft toothbrush. Reduce needle prick. Okay. They can use electric razor instead of using manual. You have to prevent fall. You have to because any form of injury, avoid sharps. Okay. Avoid rubbing after administering. No clopidogrel. Avoid hard brush. Thank you. If it is a child or a young child, they should avoid any form of contact sports. They should avoid over-the-counter medications. Okay, you don't give them garlic. Those are bleeding precautions. They should stay away from any form of all these. Please, just a moment. Yes, I said just a moment. I took permission before muting myself. I was talking to someone. Sorry about that. Okay, so there are some medical, I mean, there are some, I think you don't give them ginger, garlic, yes, because all these are like what? Natural blood thinners too. So you don't give them all these omega-3, Z vitamin A, you have to avoid, they should avoid some of these medication of these natural ginger or something. So you don't administer it to them. They should avoid over-the-counter medications. This patient should not have what? Constipation. Avoid constipation. They can bleed from there. So no flossing. No flossing. Do you know the meaning of flossing? Tell them not to floss. Please, can you still hear me? Because my network is fluctuating. Can you still hear me? Can you hear me, please? My voice is breaking. Is it still breaking? I think my network is not too good. Okay, so no flossing, please. No flossing. I hope you all know the meaning of flossing. Because when they floss, they can bleed. Okay, some people don't know the meaning of flossing. Flossing is, when you want to, all this toothpick, there is something like a rope in between them that you can use to go in between your gums. That you can use to go in between your gums and then remove all food particles. This patient should not do it. It is totally contraindicated in a patient on anticoagulant because they can have bleeding gum. They should not work in darkness. They should avoid any form of contact spot, dental flossing, like toothpicking. They should not use any form of toothpick so that they don't damage their gum and then they'll start bleeding. So I think we have tried on this. Thank you. Let's continue. So observe for bleeding gums, bruises, nose bleeding. They can have epistaxis. Unfortunately, patients on anticoagulant can bleed from any part of the body. So you have to be observant as a nurse when your patients are on anticoagulant. When your patient is having epistaxis, you know that is what? A side effect. They have started reacting to it. They are bleeding. You watch for hematuria, hematemesis, fecal occult blood. You can do a special test known as fecal occult blood test, GWAT test. You can read about it. Then petechiae. There is this like a tiny brown purplish spots under the skin as a result of bleeding. That's what we call petechiae. Then instruct the clients regarding measures to prevent bleeding. You tell them what are the things they can do, all these things that we have discussed too. Those are the things you tell them when they're on anticoagulant that they shouldn't do this. Tell them the food not to take. Then the antidote to heparin. I wanted to ask you initially, but unfortunately you have seen my slide. So the antidote to heparin is protamine sulfate. So you have to make sure that protamine sulfate is on ground when a patient is on heparin. You have to make sure protamine sulfate is on ground in case you will need it. In case you will need it. Then when administering heparin subcutaneously, inject into the abdomen with 5/8-inch 16mm needle, 25 to 28 gauge. I think we have mentioned that at a 90-degree angle and do not aspirate. This So you administer it at 90 degree and do not aspirate, do not rub the injection site. Then continue IV infusion, continuous IV infusion must be run on an infusion pump to ensure a precise day. I don't know if we use infusion pump here, I'm not sure, but you know that infusion pump will actually help to deliver the appropriate dose. You won't make any mistake. It's like everything will be programmed. So, and then you don't have to disturb yourself instead of using the manual pump. So that will be all on heparin. So now let's go to enoxaparin and rivaroxaban. Enoxaparin and rivaroxaban. You can see that in the bracket we have the LMWH. That means low molecular weight heparin. So they are also heparin, but they are low molecular weight heparin. So this was the heparin I was talking about that you can actually administer to pregnant women. Because they have less chances of major bleeding. They are less heavy. So they are a little bit different. They are also type of what? Heparin, but they are low molecular weight heparin. Please take note. They are low molecular weight heparin. So they have great affinity for what? For factor XA in providing anticoagulants. So all these factors, they play a role. That's why I say you need to go and read blood coagulation pathway so that this will make sense to you. So this low molecular weight heparin, they have great affinity for factor XA in providing anticoagulation what? Action. So they provide a predictable anticoagulant response. Enoxaparin and rivaroxaban have the same mechanism of action and use as heparin, but are not interchangeable with heparin. So they are low molecular weight. You cannot interchange them with what? Heparin. They are just a type of heparin with lower what? Lower molecular weight. They have longer half-life than heparin. They are less heavy and there are less what? Chances of major bleeding. There are less chances of what? Of major bleeding. What are the indications? Prevention of operative deep thrombosis, pulmonary embolism, prevention of ischemic complications in unstable angina. We have different types of angina. We have the stable, the unstable, we have the Prinzmetal angina. And you can also use it in ST elevation myocardial infarction. So this was what I was referring to EKG. And I asked that, okay, how many people want me to talk about EKG later? I think only 2 people responded. So, for you to understand what we mean by ST elevation myocardial infarction, you need to note the EKG. Because the EKG, on the EKG strip, we have the PQRST. So that particular ST, there's something you will see it on the EKG strip. It is usually elevated. So that is why we call it ST segment elevation myocardial infarction. There is a way it appears on the EKG strip that will make you to know that, this patient is having ST segment elevated myocardial infarction. But without the knowledge of EKG, you can't know it. And EKG is a whole course on its own, not just a topic. It's a whole course on its own. So side effects, bleeding episodes, heparin-induced thrombocytopenia. So it can also cause what? It can also cause heparin-induced thrombocytopenia because it is also heparin. Please take note. It is a type of heparin, just that it has a lower molecular weight. So it can also cause heparin-induced thrombocytopenia. Then contraindication, presence of any active bleeding, increased risk of what? Hematoma in patients with spinal or epidural anesthesia. You have to use with caution with concurrent use of aspirin, clopidogrel, and other antiplatelet. Not to be used in the presence of what? Thrombocytopenia, of course, we've known that. What are your nursing responsibilities? Administer enoxaparin only by subcutaneous injection into the anterolateral or posterolateral abdominal wall. Do not expect the hair bubble from the peripheral syringe or aspirate during injection. Do not rub the site. Then rivaroxaban is taken orally. So I had to combine the nursing responsibilities and then state the exact medication that I'm talking about so that you can understand. So rivaroxaban, we administer it a lot. It is taken orally once daily. You have to, so for this particular medication, you monitor the result of anti-XA assay. So when you read your blood coagulation pathway, you understand what this factor XA, what it does. When you read your blood coagulation pathway, you have a deeper understanding. So the therapeutic range for anticoagulation is 0.5 to 1.2 international units per mil. You have to monitor your patient for bleeding. The antidote to this low molecular weight heparin is also protamine sulfate because it is a type of heparin. Any questions so far? Before I continue. Are we still together, please? Yes, I just spoke about the part. I said for you to understand, we have different factors that plays a role in the blood coagulation pathway. We have factor 2, we have factor 10, we have factor 12, we have factor, we have a lot of factors, depending on whether it is in the extrinsic pathway or intrinsic pathway or the common pathway. So I said for you to have a deeper understanding, all this mode of action of all these anticoagulants, you need to have the knowledge. And this class is not for blood coagulation pathway because it's a whole lecture on its own. So you go back to your blood coagulation pathway and read it so that you understand what all these factors, what they do. This factor SA. So that's why I'm saying, okay, you have to go back. We have different factors that play a role. We have factor 2, we have factor 7, we have factor 9, we have factor 10, we have factor XA. So I was like, okay, if you really want to understand, then go back to the knowledge of your what? Of your blood coagulation pathway. So I hope I'm making sense now. The antidote is protamine sulfate. It's the same thing. You are still going to use the antidote. It's a type of heparin. So it is the same thing. Just that they have low molecular weight. They have less chances of what? Of bleeding. So nursing responsibility. Always double check. Always double check. Cannot be given to a patient receiving heparin. I told you that they are low molecular weight heparin. Then injections in the abdomen should be 2 inches. We all know this. I shouldn't be reading all this. We all know this. You give it 2 inches from the umbilicus. Advise patient not to take over-the-counter medications. I hope you know all our over-the-counter medications. Then check complete blood counts, especially platelet counts. You still have to monitor the platelets because of heparin-induced thrombocytopenia. You have to monitor for bleeding, GUAT2 for occult blood, then monitor for hematuria, bleeding gums, excessive bruising. Does not require activated partial thromboplastin time. So you don't need it here. Does not require you to monitor the what? The APTT. Just monitor the what? The platelet count. Because it is not you only need that thing when you're administering what? Heparin. I hope I'm making sense. So you only need to monitor the what? The partial thromboplastin time when you're administering. But these ones are what? They are low molecular weight heparin. So it does not require it. Just monitor the what? The platelets. That's all. So now warfarin sodium. I hope we can continue. So can I move on? Our time is fast spent, almost 6. And I don't want us to go beyond 6 something. So that means we still have to schedule class by next week. So can I move on, please? Okay, so I don't know why I'm not seeing your responses. Like, okay, I think I get it now. All right, thank you. So let's go to warfarin sodium, Kumadin. Now let's talk about warfarin. Warfarin suppresses coagulation by acting as an antagonist of vitamin K. So now, before I continue, what is the antidote for warfarin? Please respond though. What is the antidote? We have talked about protamine sulfate. That is the antidote for heparin. So what is your antidote that you use to counter the effect of warfarin? What can you give to patients? Thank you, vitamin K. All right, thank you. So I deliberately asked so that you can understand the mode of action. Okay, so it suppresses coagulation by acting as an antagonist of vitamin K. Vitamin K plays a role in blood clotting. We all know that. So, but unfortunately, warfarin, how will I put it now? There are 4 dependent clotting factors that depends on vitamin K to carry out their work. So these are the dependent factors in brackets. We have factor 10, factor 9, factor 12, and factor 2. Please take note. These 4 factors, they cannot carry out their work. Warfarin works in the extrinsic pathway of blood coagulation pathway. That is where warfarin works. It works in the extrinsic pathway. So there are 4 dependent factors in this extrinsic pathway that depends on vitamin K to do their own job. They can't just stand alone. They cannot do their work without what? Without the help of vitamin K. So what it will now do is that it will suppress coagulation by acting as an antagonist. It will go and antagonize what? Vitamin K. So it will suppress the action of vitamin K, it will antagonize it, so that those four dependent factors will not be able to do what? They will not be able to do their work. That is just the mode of action of what? Simple way that I can explain that it will be meaningful to you. So warfarin will act as an antagonist of vitamin K, so that those four dependent factors, those four factors that are dependent on vitamin K, will not be able to what? They will not see something to depend on. So that is how warfarin works. So warfarin prolongs clotting time, and it is monitored by prothrombin time. You know, I was telling you initially that PTT and PT are not the same thing. Prothrombin time is the time that takes your plasma, the plasma part of our blood, to clot. So that's prothrombin time. Then you monitor the what? The international normalized ratio. So this is what, please take note of. These are the two things you monitor in a patient that is on what? On warfarin. These are the two things you monitor in a patient with warfarin. In heparin, you monitor the what? The PTT and what? I hope I'm not the only one in the class. Oh. Thank you. Thank you, PTT and APT. Thank you. All right. Okay. So for warfarin, you monitor the PT, that is the prothrombin time, and the INR. We call it international normalized ratio. International normalized ratio. So it's just like a standard number that is figured out in the lab. We call it international normalized ratio. And the normal prothrombin time is 11 to 12.5 seconds. That is the normal one, 11 to 12.5 seconds. So by the time you are now talking about the therapeutic range now, you will now multiply it by 1.5 to 2 times. So once you place your patient on warfarin, then you can now multiply, you expect the coagulation time to extend by 1.5 to 2 times. Like exactly the way we explained it in the what? In the, when we're talking about the heparin. So, but this one is now 1.5 to 2.5. That is the control value. So when you multiply 11 by 1.5, then 12.5 to 2. What will it give you? Please, let's do the maths. What will you get? Multiply 11 by 1.5, then multiply 12.5 by 2. What will it give you? I want you to do it so that you can get what I am saying. Okay, 16.5 to 12.5. So that is what you are expecting when you place your patient on what? On warfarin. So now, what is international normalized ratio? Have you heard that before? What do we mean? Please, who can tell us so that we'll round up very soon? International normalized ratio. Some of these details explanation are not in our handout. Well, that's not why we are here. You are here because you want to learn, not because you want the lecturer to keep pouring out what is in your handouts. The most important thing is that you are learning it now and you have access to the material. I think that's the most important thing. Please, who can tell us international normalized ratio? Well, because of our time, it tells you how long it takes for your blood to clot, and it is used to test clotting times in people taking warfarin. So I think it's just a standard ratio that is determined in the lab. So the normal value is 0.81. Okay, thank you. How quickly? All right. So you use it for patients taking warfarin. That's where you use this INR for patients taking warfarin. You don't use it for those taking what's it called? Heparin. So the normal INR is 0.81 to 1.2. Is 0.81 to 1.2. I've told you that of prothrombin time. So the treatment goal of warfarin sodium is to raise the INR to an appropriate value. So it's raise the INR and appropriate. So the normal INR is 0.81 to 1.2. That is when your patient is not on warfarin. But now an INR of 2 to 3 is appropriate. That is the standard. When your patient is now on warfarin therapy, I think it is just the standard. You can see that in this one, there is no multiplication. If you notice, they didn't give us any value to multiply. If you are looking at it, and I don't know, don't ask me why. I'm not a lab, I don't know, lab scientist. So I just know that here now, there's no value for you to multiply. They have made us to know that once you commence your patient on warfarin sodium, then just expect the INR to be within 2 to 3. That is appropriate. And INR of 3 to 4.5 is appropriate for high dose. You know, there's something we call high dose warfarin therapy. It's different from normal warfarin therapy. High dose. So when you are giving your patient higher dose warfarin therapy, then the normal INR we are expecting is 3 to 4.5. So if the PT value, prothrombin value, is longer than 30 seconds, you know I told you to multiply that 11 to 12.5. I told you to multiply it by 1.5 to 2. And you are giving me the answer. So now, using the answer that you got earlier on, if the PT value is longer than 30 seconds, and the INR is greater than 3.0, I hope what I'm saying is making sense. In a client receiving standard warfarin, you initiate bleeding precaution. So I think I've explained this when I was telling you about heparin. So I don't want to start explaining again. You understand definitely that if the PT value is now longer than 30 seconds, that means your patient is prone to bleeding. And the INR is more than 3. Your patient is already prone to what? It's already prone to bleeding. It is too long. Then you initiate what is known as what? Bleeding precaution. If the INR is below recommended range, warfarin sodium should be what? Should be increased. If the INR is not up to what? If it's not up to 2, your patient is on warfarin and you have checked the INR, the international normalized ratio, is below 2, then that means you should increase the warfarin sodium. Client may sometimes be prescribed bridge therapy. Bridge therapy, whereby heparin sodium is used concurrently with warfarin sodium until the INR reaches the recommended range. Once this occurs, the heparin is discontinued. And why is this? The reason why is that heparin works faster. Within minutes, if you administer heparin to a patient, then the blood starts what? It starts its anticoagulation work, but it wears off quickly. It wears off before you know it. But warfarin, how long does it take warfarin to work? When you place your patient on warfarin, how long does it take it to work? How long? The onset of action. Who can tell me the onset of action? How long does it take for warfarin to work? Let's say you commence your patient on warfarin today. Okay, when are you expecting to see the result of the warfarin? When? What time? What day? Please let's respond. 24 to 72 hours. Thank you. Okay. Someone has responded. Okay. That's a day to 3 days. Okay. Another response. 72 hours, 3 days. Okay, 2 to 3 days. Thank you. Yes, warfarin can take as high as 5 days, even 7 days before it start working. It has a very slow onset of action, very, very ridiculously slow. So now, if you start your patient on warfarin today, you can actually, the bridge therapy means you can actually start your patient on heparin too. Because are you going to watch your patient? Are you going to watch your patient's blood to coagulate for the next 3 or 4 days without looking for a way out? So that is what we call the bridge therapy. So you can actually commence your patient on those 2 therapy at the same time, so that heparin will cover up for the days that warfarin has not started working. And immediately warfarin start working, then you discontinue the heparin. That is what we are talking about here. So warfarin sodium takes a very long time before it starts working. Indication is used for long-term anticoagulation, is used to prevent thromboembolic conditions such as thrombophlebitis, pulmonary embolism formation caused by atrial fibrillation. I think I've explained this atrial fibrillation just briefly. Thrombosis, myocardial infarction, valve damage, contraindication, bleeding disorders, lumbar puncture, vitamin K deficiency, and I think you know why now. So I don't need to tell you why it is contraindicated in vitamin K deficiency because I've told you the mode of action. So you should be able to what? Relate it together and know why it is contraindicated in a patient with vitamin K. Then severe hypertension. In a patient with severe hypertension, pregnancy, breastfeeding, liver disease, alcoholism. Why is it contraindicated in liver disease? At least you have known why it is contraindicated in vitamin K. So why do you think warfarin is contraindicated in a patient with liver disease? So I want to know if you really understand the pathology or mode of action. Why do you think it's contraindicated? Let's think. Why? Why is warfarin contraindicated in a patient with liver disease? I'm looking at your chart. Nobody is responding. Let's talk now. This thing is not hard though. Let's just think about it. Risk of bleeding. No, please. Don't let's respond like a layman. Let's respond like nurses. Risk of bleeding. It prolongs the action. That is the organ that metabolizes the heparin or warfarin. No, you are wrong. That's not the reason why. There is something I want you to say. Who can try? Someone is laughing. That's the organ that we know. Liver stores vitamin K. Okay. We are getting there. Thank you. God bless you. Alamuyobola. Liver produces clotting factor. God bless you. Yeah. Thank you. Yeah, liver plays a role in blood clotting. Thank you. This is what I want to hear. So, warfarin blocks the liver from using vitamin K to make clotting factor. Okay. So, liver produces clotting factor. But the liver here, this patient is having liver disease. So, when any patient with liver problem, please no liver produces what? Albumin. It produces bile and clotting factor. So a patient that has liver disease, do you expect them to produce enough clotting factor? And you still now want to go and jam pack them with warfarin? What will happen? They will bleed to death. They will bleed to death. They will bleed to death. So all our responses here, at least the latest responses, are very okay. Thank you very much. Thank you very much. So the same thing with alcoholism, liver and alcohol and liver cells, they are not friends. So it's just more like the same thing. So that is why it is contraindicated. Thank you. Okay. So side effects, spontaneous bleeding, hypersensitivity reaction, red-orange discoloration of urine. Please don't mix it up with a bacteria. It is not. Red-orange discoloration of urine. That's also a major side effect. Then weakening of the bones with long-term use. When you use warfarin for a long time, it can cause osteoporosis. So you monitor the PT, INR, then it interacts with large number of medications consequently. So evaluate medications for interaction before initiating therapy. I've told you there are a lot of things that you don't want to use with antiplatelets. So you don't want to use it with thrombolytics. So except in some conditions. So monitor for bleeding tendencies. Then vitamin K, which is also known as phytonadione, is the what? Is the antidote. Teach patients to maintain, excuse me, intake of vitamin K. Keep constant intake. So your patient, that's not the time to say, I want to stop taking vitamin K, food rich in vitamin K. No, why should they do that? There is no need. Just tell them to keep constant intake of food, such as green leafy vegetables, mayonnaise, canola oil, food rich in vitamin K. They should just maintain it. They should not increase or decrease. They should not totally stop it. Do not abruptly increase or decrease the intake. Patient must inform all healthcare provider if they are taking warfarin, because it is very slow to be excreted from the body. You know that when your patients are going on surgery, that is why your patient cannot be going on surgery tomorrow morning now, and you now go and discontinue vitamin K in the night. That's totally wrong. Discontinue warfarin. No. So because it takes a long period of time, it takes time. Its onset of action is very slow, and even it also takes time to leave the body. So teach patients to wear a medical lab bracelet. Then another type is Dabigatran. I don't know if this one is in your study material, because most of the things that I picked them from your study material. So this dabigatran, it works through direct inhibition of thrombin. So this one is a direct thrombin inhibitor. It is a direct thrombin inhibitor. So this one can actually inhibit thrombin by itself. It doesn't have to depend on antithrombin 3 to help it. So this one can inhibit the thrombin by itself so that fibrinogen will not be converted to what? Fibrin. So indication, it prevents strokes, systemic embolism in patients with atrial fibrillation, which is not related to cardiac valve problem, precautions, pregnancy, active bleeding episode, patients undergoing spinal puncture, epidural anesthesia. It should not be combined with other anticoagulants, concurrent use with antiplatelet drugs, and fibrinolytics should be done with caution. So, patient with severe renal or hepatic disease, all these are what you should take precaution. What are the side effects? Bleeding, gastrointestinal disturbances, dyspepsia, gastritis-like syndrome. What are the nursing responsibilities for this particular medication? It's also a type of anticoagulant. Don't forget that we have been discussing about what? Anticoagulants. It does not require monitoring the APTT, INR. So you evaluate and monitor patient for bleeding risk. Patient should take a mixed dose as soon as possible. This particular drug, patients should take a mixed dose once they remember, but not within 6 hours of next scheduled dose. Then dabigatran, after container is opened, medication should be used within 30 days because it is sensitive to moisture and should not be stored in a weekly pill organizer. There is this particular weekly pill organizer that you can arrange your pill. So it is this, but dabigatran, you cannot use a pill dispenser for it. It is wrong. So take with food to decrease gastric side effects. And it's not to be crushed, but taken as a whole. Do not crush it. It is contraindicated. Tell your patient not to crush it. What are the substances to avoid with anticoagulants? What are the substances you should avoid when your patient is on anticoagulants? Allopurinol, can you see? I've been saying it. So when taking history or patients, you want to place patient on anticoagulants, you have to let them know, or you have to ask them their history, which drugs are they using presently. So that you will know if they can actually combine that medication with anticoagulants or not. Allopurinol, you don't want to give it with anticoagulants. Cimetidine, corticosteroid, fluoroquinolones. Who can tell me an example of fluoroquinolones? Nurses or pharmacology nurses. Which drugs are known as fluoroquinolones? Thank you. All right. Okay. So all these ginseng, and all those herbs, all those herbal something, you don't want to give it together with herbs. Then macrolide antibiotics. I'm sure we know macrolides too. We have different types of antibiotics. So macrolide specifically, all our non-steroidal anti-inflammatory drugs, oral hypoglycemic agents, phenytoin, salicylates, sulfonamides. Avoid with anticoagulants. So we have come to the end of the lecture. This is 6:01 already. I've been targeting 6 o'clock. And I'm glad I was able to meet up. So I think we still have, if not because of the time, I wanted to have the lecture with you in the morning so that we can have another, we can talk on, I think, antiplatelets and thrombolytics. But unfortunately, our time is fast spent. So any question? So we'll fix the lecture for another time, actually. Any question? Let me stop recording. Any question?